Yes. So now I think we'll begin the session. Dr. Balu, can you stop sharing the screen and then we can
Give the presenter role to
share it
someone
once
else
we...
immediately, so it will automatically stop.
Yes, yes, yes.
Give the presenter
Thank
role to someone.
I will give it to Dr. Hina only. Yes. Okay. So I'm going to start with the the program today. I have received a message from Professor Santosh. He will not be able to join. So he has asked us to go ahead today with the technical sessions. So I will start here, and good afternoon to everyone. So all our domain experts who are present here today as our speakers, and all our participants that you have joined today. I know it's a holiday today and still people joined. Thank you so much. And today's webinar is titled Sexual and Reproductive Health and Rights of Women and Adolescent Girls During Disasters and Emergencies. So this webinar is being organized by CCDRR Center of NIDM. CCDRR is basically a child-centric disaster risk reduction center, and it's a center of NIDM, which comes under Ministry of Home Affairs. And this webinar is being conducted under the patronage of Major General N.K. Bindal, Executive Director, NIDM, and the guidance and supervision of Professor Santosh Kumar, who is also the project director of CCDRR Center. So just a brief introduction to our topic and why we are doing this topic today. Sexual and reproductive health and rights, basically, popularly also called SRHR or SRH rights, are related to multiple human rights. And these rights range from right to life, right to health, privacy, prohibition of discrimination, right to education. And as you must have already guessed, that these rights are also embodied in our fundamental rights, which are given by the Constitution of India, right? So when we talk about these rights in the context of a disaster, we see that in crisis, the challenges faced by women and girls pertaining to their sexual and reproductive health needs are, magnified. And this, when we couple this with a pre-existing gender, economic, and other inequities like caste, region, tribe, ethnicity, they are put at disproportionate risk and vulnerability. And we have seen this in current ongoing COVID pandemic, that disasters also exacerbate the gender-based violence, including sexual exploitation and abuse. And this is, this happens, and then there is lack of space, there is lack of amenities and facilities for SRH in our country and globally. And these facilities range from WASH, that is water, sanitation, and hygiene amenities, hygiene products, be it menstrual products, soap, water, then health infra and personal. There's dire lack of health infra and personnel when it comes to uh, SRH, and this prevents women from accessing their needs and rights. And these needs and rights, we have to ensure that they are accessed in a safe, private, and dignified manner. And furthermore, there is this taboo and stigma and shame, and then secrecy attached to this subject matter at hand today, and which presents a serious barrier to their accessibility. And women are usually made to feel ashamed, and they are so uncomfortable to even speak about their very pressing needs. So hence, we see that this is a very, very underserved area, very, very understudied area. Even when I was approaching a different resource persons, it took me around a week to narrow down different resource persons for this particular topic. So this made me realize that when we say that there is lack of focus on this area, I mean, it really is, because I was not with all the NIDM's resources. Also, sometimes it was very difficult to get, in touch with resource persons. So there is this need to strengthen integration of SRHR in disaster risk reduction, response, and recovery process, right? So now today, our speakers are going to talk about this. They're going to take you through this entire process by explaining what these rights actually are and how we can, have an action-oriented approach towards these rights. So without further ado, I will like to invite Dr. Hina Hijazi today as our first speaker. So, ma'am, before we go ahead, I would like to give the attendees a bit of your introduction, so that they know that so that they know about your work and they can relate with it. So, Dr. Hina Hijazi, she's currently working as Senior Manager Programs Sphere India. And she is a humanitarian and disaster management professional with over 15 years of experience in project management, advocacy, capacity building in the field of emergency preparedness and response in India, Nepal, Bangladesh, and Kenya. She has been part of multi-sectoral projects on relief, response, rehabilitation, gender in DRR, psychosocial support, SRH in emergencies, health emergency, and preparedness for response, social development, natural resource management, school safety, education, and WASH in emergencies. She has worked with humanitarian and disaster management resilience organizations like Action Aid, International Committee of Red Cross, Sphere India, United Nations Population Fund, that is UNFPA, WHO, IPPF, Pragya, and its member agencies. Dr. Hina has earlier worked as a thematic lead capacity and knowledge management and has been instrumental in establishing partnerships and garnered support from government, UN, sphere member agencies, and NGO networks for capacity building and disaster preparedness across India. She has imparted knowledge and skills on SRH in emergencies and MISP, that is minimum initial service package, which she'll be talking about in her presentation as well. And she has imparted this to almost 3,000 SRH advocates on sphere minimum standards and protection principles post emergencies. And she has ensured adherence to humanitarian response standards and worked with humanitarian clusters therein. She is presently the sector coordinator for health and program lead of Sphere India's overarching vertical naming accountability to affected population and advocates for protecting the rights of the most vulnerable and marginalized. Thank you so much, Dr. Hina, for agreeing to be a part of this exercise with us today. Over to you, ma'am. You can, handle your
Thank you so much, Dolphy, for a very, very impressive, a very prolonged introduction. It wasn't required. I'm humbled and honored. At the outset, I would like to congratulate NIDM for conducting a session on this very, very important, critical topic, which many of us shrug behind the carpet. And because it's not given a lot of priority, as you've rightly said, but you will be happy to know. And today, as I introduce myself, I also introduce myself very proudly as being a MISPian, as being an SRH advocate, and having worked considerably over the length of some 5 or 6 or 7 years, primarily on SRH and disasters in the country. So I would like to introduce this book to all of you all. I don't know whether this is visible to everybody here. And Dolphy, to you and to our NIDM colleagues also. Now, this is the brainchild of National Disaster Management Authority. This booklet is a manual and a module on minimum initial service package for sexual and reproductive health in disasters. A very, very exhaustive manual. And, it talks about how India needs to be prepared on SRH and emergencies in the country, and how we can strengthen coordination, how we can increase the capacities at the state and district level for everybody to implement SRH and to implement MISP. We'll come to know more about MISP, minimum initial service package for sexual and reproductive health in disasters, and how to respond in a very timely, in a very effective manner to SRH needs. As I said, this book is primarily the brainchild of NDMA, and it has come from NDMA. It has been vetted by NDMA, and UNFPA, which is United Nations Population Fund, has technically supported in the development of this module. and Spare India. Spare India is a national coalition, and you've largely talked about what Spare India does. Spare India has been instrumental in rolling this out in almost 20 to 22 states of the country, with an aim to create SRH coordinators, SRH advocates, and people who can implement SRH in emergencies and disasters to save lives. So with this, I would like to start my presentation by showing a small video, an animation video, to all our viewers and attendees and participants, which will give them an overview of what we are going to discuss for the next half an hour. So I have to click on this button, is it, Dolphy?
No, ma'am. Please give me a presenter role. I'll play the video.
Okay. Yes. Dr. Balu will run the video. Just a moment, Dr. Balu. I am giving you the presenter role. Have you received it, Dr. Balu?
No, not yet. It's not enabled till.
Now?
No, ma'am. Yes.
Okay.
Yes, I'm sharing.
Okay. There are some bandwidth issues. It's good that everybody of us do not keep our cameras on, because that also leads to some problems.
Thank you, Dr. Hina. Now, shall I start with your presentation? You muted. Just a moment, I will unmute.
So much, Dr. Balu, for putting this out. And I'm sure all the viewers and all the participants have enjoyed seeing the video and must have got a lot of idea on what we are going to discuss for the next half an hour or so. And so this has been used as a very powerful tool, this animation video, to all the policymakers, service providers, right from the national level to the district and the block level, trying to convince, motivate, sensitize, make aware different policymakers on what are the needs in the field and how we need to be better prepared in terms of coming out with robust mechanisms to deal with SRH and emergencies. Can we have the presentation now?
Yes, ma'am, I'm sharing it. Just let me know when it gets shared. Am I able to, is it visible?
Yes, Dolphy, if you can zoom this, that'll be
Yes.
really helpful. Yeah, thank
Yes.
you. Over the my topic for today's presentation is overview of SRH in disasters, with a special focus on a project that we have rolled out in the country, which largely talks about the implementation of SRH in disasters, and we call it as MISP, which is Minimum Initial Service Package for Sexual and Reproductive Health in Disasters. So these are the two broad things that I'll try to capture in my session. Next. Yeah, so I come from Spare India. Spare India is a national coalition. I cannot see all the, I mean, they're coming in piecemeals. Okay, now it's visible. Spare India is a national coalition of humanitarian agencies founded in 2003. We have this coalition comprises of more than 93 member organizations, which are national organizations, international organizations, UN organizations, government organizations, CBOs, CSOs, and 26 state interagency groups and 805 local partner agencies. Now, we largely look into interagency coordination for emergency preparedness for response. We look into collaborative advocacy and knowledge and capacity sharing through a collaborative process for accountability to affected and at-risk population. So these are some of the member agencies who are our members, and there are we started off with having agencies which were like 20, 30. Today we have a member agency's roll of more than 93. We have certain program verticals, which I said, coordination, advocacy, and capacity building. And then we also have certain sectoral horizontals, which are as per the life-saving sectors: health, wash, nutrition, shelter, education, protection. So this is how we function, and this is how we take our vision towards adhering and advocating for the global minimum standards, bare minimum standards in disasters and emergencies. Next. Now, India is vulnerable to a host of natural disasters like flash floods, cyclones, earthquakes, droughts. Disasters can change life in an instant. They can displace people, leave them homeless, destroy basic infrastructure. During disasters, families and individuals are often left without basic necessities like food, water, hygiene, medical care. In the aftermath of a disaster, as you have very rightly seen in the video, pregnancy-related deaths, sexual violence, it's estimated that almost 1/4 of the population at any given point of time is pregnant, out of which also 15% experience obstetrical complications, risking their lives. This is because during disasters, skilled birth attendants and emergency obstetric care often becomes unavailable, increasing the risk of death and injury. Now, we will take you through some of the snapshots. Disasters are deeply discriminatory processes that affect women, men, girls, and boys in significantly different ways. And if we can also take you through some of the glimpses, Dolphy. Now, impact of natural disasters on reproductive health can be devastating. Communities are suddenly deprived of reproductive health information and services. You see this lady here who was pregnant and in a displaced camp, and she has children as well. And there's this other picture with women taking, there's a relief distribution going on, and they are having access to hygiene kits. Women have their specific needs, special needs, which at the time of disasters continue to be there. These are families who are displaced from their original settlements, and they have special needs and need special requirements. The second one, usually access is cut off, the needs persist or may even escalate. A large number of disaster victims and displaced women will be pregnant, like you see this woman who has been ferried in the floods and been taken to the hospital as she developed labor pains, and they undergo delivery in very hostile settings also. I remember of a case that I heard and which was very much in the news, where a lady, while escaping flood waters of tsunami, climbed a tree and remained at the top of a tree for 3 long days, and in the meantime delivered her baby at the top of that tree. So these are the dangerous, unhygienic, the conditions which render us more vulnerable and which can lead to increased mortality, morbidity during disasters. These very much prevail. If we can move to the next slides. There's this lady who has given birth to a newborn kid at the makeshift shelter. Next. So during disasters, this absence of law and order, men lose their power, their status, their income. Single women, especially the ones who've lost their bread earners or their husbands or their sons, are vulnerable to sexual abuse. We're talking about people who live in displaced camps. They're more prone to violence, to rape, even to exchange of sex for food or protection. We may think that in India these things do not exist, but by experience, since we've been a part of many disasters, child trafficking, all these kind of issues are quite manifest. There is increased demand, but there's insufficient supply. SRH needs always continue, whether it's disaster times, it's not disaster times, but of course in disasters and emergencies, the needs do escalate. And what are some of the usual manifestations? There are risks of sexual violence which may increase. There is every chance of having HIV, STI transmission, since the commodities, the supplies, the demand is huge while the supply is very less, which is when you're not maintaining the universal precautions and you fall prey to all these kinds of issues. Lack of family planning increases the risks associated with unwanted pregnancies. Malnutrition and epidemics increase risks of pregnancy complications. Childbirth occurs on the wayside. Now we see many disasters where we have constantly been seeing children being giving birth on the wayside, during population movements or during normal disasters, floods, earthquakes. Lack of access to comprehensive emergency obstetrical care increases the risk of maternal death. We're talking about basic emergency maternal and neonatal care, BMOC services. Can we move to the next slide, please? Now, ICPD, ICPD, I don't know how many of us know about ICPD. In response, this is a reproductive health definition, which we see here. So till 1994, this reproductive health, we were never seeing in the prism of a human right. In 1994, International Conference on Population and Development, India is a signatory to ICPD. For the first time, acknowledged reproductive health as a human right and as a matter of choice for individuals. And that's how the definition of reproductive health changed to what it stands like now. Reproductive health today implies that people are able to have a satisfying and safe sex life, and that they have the capability to reproduce and the freedom to decide it, when, how, often to do so. It also includes sexual health, the purpose of which is the enhancement of life and personal relations. So this is the definition, which was more open-ended and which was after a lot of deliberations and after coming to know about a lot of humanitarian situations across the world, where we understood that there are issues pertaining to family planning, pertaining to reproductive health, pertaining to violence against women, and a whole lot of other things. And then it was acknowledged. So then this term was coined. Next. Some conventions and human rights instruments also support ICPD. I would leave it to Anuba to give us more details on the legal provisioning of these. And of course, next slide will be on the similar needs for, similar rights to SRH for refugees as well. Next slide. For refugees also, we have the specific rights. And then now we come to the slide, which usually 20 years ago, women's health and rights were just at best an afterthought in humanitarian response. However, now we have taken a quantum leap in terms of many humanitarian practitioners and organizations, including essential services, basic SRH services, and comprehensive SRH services in our planning. Many a times the basics are, not prioritized to the extent that they should be, but comprehensive SRH services are given more emphasis. But here I'd like to mention the definition of disaster. See, in the context of SRH and emergencies, and today we are primarily talking about sudden disasters, which have two essential components. One, there is the need of urgent attention. And second, there is a need for putting additional resources because it exceeds the coping capacity of that particular community where the disasters have stricken. So in the context of these disasters, what is required is an essential, immediate, service. And then we cannot think about only comprehensive health services. Another definition which WHO coins for sudden disasters is that when the CMR, which is the crude mortality rate, becomes 1 for 10,000 population per day. In stable situations, the CMR is 0.2 to 0.3 per 10,000 per day. So we're talking about sudden disasters. We're talking about when the death rate and the mortality is at an all-time high. And in those, we need to put out certain immediate things vis-a-vis the prevention of maternal and infant mortality, reduction of the transmission of HIV, and preventing and managing the consequences of sexual violence. We can move further. As we said in the first slide, that women and girls are disproportionately disadvantaged. More than 100 million people are in need of humanitarian assistance. 1/4 of these are women and girls aged 15 to 49. And these are the people who are at an all-time risk of STIs and HIV, unintended unwanted pregnancies, maternal death and illness, and sexual and gender-based violence. So thinking about building our implementation programs, of which MISP is also talking about the same thing. Next slide. Just showing you some stats of the recorded natural disasters by type from 1994 to 2014. The idea is just to give a bird's view to the audience here, to know that how the disasters are coming to an increasing, have a very increasing trend, and they're not coming down, but every year we see so many disasters affecting the entire globe. Next slide. I'll also show you some very startling stats. These are fact sheets which are taken from different reports, different journals, different studies that have been going on. Over the past 20 years, there have been an average of 340 disasters per year. Floods account for 43% of all disasters during that period. Earthquakes and tsunamis together claim nearly 750,000 lives during that 20-year period. So this is humongous, and it may give us an idea about how big a problem we are dealing with. And the next slide, which is more specific to some startling reminders on the percentages for SRH, related to SRH, which is 75% of the affected population comprises of women, children, and adolescents. 4% of women at any point of time are considered to be pregnant. For example, an area has a population of 2,000, so 400 women will be in their second or third trimester who may require immediate attention, or who may require medical supervision, or who may require 15% out of these 4% will face life-threatening obstetrical complications, and 50% of the maternal deaths occur after delivery in the first 24 hours. So again, we will move further. So why are SRH services for populations? Why should we have SRH services for populations in disasters? One very important thing, it's a human right. We talk about the Constitution of India, and Dolphy in the initial part was talking about the concept of everybody having a human right to freedom of speech, right to make your own decisions, right to equality, right to access to all the basic essential services. So similarly, we should not sideline and say that sexual and reproductive health is not our right. All the things pertaining to this do come under a right, and it is the Constitution of India has given us this right also. And second, it's a biopsychosocial health need. We cannot say that in disasters we do not have needs. We do have needs in disaster time, in non-disaster times. SRH will continue to be a need and a requirement. So when we talk about, in disasters, we'll have to abstain from this, but it continues to be a need, and there continue to be, implications associated with it. So let us move further. I would briefly like to talk about this interagency working group. Now, after this 94 ICPT conference, and in 1995, in response to the problems which were identified in the humanitarian settings, to the ICPT program of action, a group of 30 UN agencies, NGOs, international academic and donor institutions formed the Interagency Working Group on SRH in refugee situations. It used to be called in refugee situations earlier, now it's called in humanitarian situations. Group's main tasks were to advocate for, organize, and facilitate SRH services in humanitarian settings. Now, WHO is the technical standard setting agency for this group. Over the years, the group has developed several tools and started with the MISP for SRH in disasters, which was developed in 1995 and is described in the Interagency Field Manual, which you can see here in this picture. There is a field manual which was developed earlier, which comprised of information on 4 basic themes, which are also enlisted here. So the first manual did not have family planning, and subsequently with the new manuals, we had more provisioning and more thematic areas being added to the manuals. If we can move to the next slide now. No, the MISP manual, you skipped one slide. So this is the manual back. Yeah, so this was the initial manual on the left hand side. On the right hand side, we find the the second one, Dolphy. Yeah, so this one that I showed all of you all is the manual that we developed actually in India in context to some key challenges for SRH in disasters, which were primarily that SRH and gender were not seen as a priority. There was a lot of lack of data on SRH, and there was indeed a lack of capacity, know-how, knowledge to plan and implement. We didn't know, and the policymakers, the service providers, the doctors, the disaster management professionals at the state levels did not have any idea about SRH. This is way back, in 2010, 11, 12, and a lack of knowledge amongst service providers, lack of integration of SRH in policies and programs. So to cater to all of these, this manual was developed, and accordingly, the topics were also assigned and the objectives were also set out in this manual. If we can move further. Yeah. Now we come to what is MISP. So before saying this, during disasters, there's a lot of chaos. And you cannot put in place all the components of comprehensive SRH. You have to limit your interventions to life-saving SRH activities. The Interagency Working Group argues that a minimum of SRH services should be a part of the primary healthcare measures in early disasters, and as such define the MISP. So this does not. This talks about a package, but this is not a box and which can be opened out, and this is more of a strategy that includes coordination and planning, and of course with providing some SRH supplies and a set of activities. So together we call it the MISP. Let us try to see what it entails. Minimum meaning basic limited reproductive health, which means the minimum things that we can do, the most basic things that we can put in place. Initial means at the onset of an emergency, of course, without any need of putting any needs assessment. As I said, we already have stats that 1/4 of the population must be afflicted. So this does not require any pre-information, any needs assessment for putting in these set of activities into positioning. Service means the facilities that are provided to deliver to the population, to the affected population. And package, as I said, through coordination and planning, put out a strategy which has a list of supplies, commodities, also which is a sub-component, but that is not the large part of what it is all about. So next one. So as I said, MISP includes equipments and supplies, is a cluster of RH services to meet the minimum requirements in a disaster situation with the expectation that comprehensive service will be provided as soon as the situation permits. Here, we talk about basic services. We do not talk about comprehensive SRH services. MISP can be implemented without a needs assessment, and MISP was developed by Interagency Working Group on RH, and countries are expected to include MISP as an integral component of their preparedness plans. Next. Now here we see the goal as well as the objectives of MISP. The goal being to increase access to SRH information and services for population affected by emergencies, natural as well as man-made disasters, while as the objectives are threefold actually: increasing the capacity of the key stakeholders, strengthening the coordination of the SRH responses in disasters, and raising awareness on SRH and disasters at national, state, district level. So it'll be capacity building, coordination, and advocacy. These are the three broad pillars which will help us respond in a very timely fashion to SRH needs in disasters. Next. Now, this is a very interesting picture talking about the continuum of an emergency. Now, the role of MISP in the continuum of a disaster is very clearly highlighted in this orange section. No, you'll have to come back. Yes. So is very clearly reflected in this orange section that we find in this slide, where the loss of essential services is there, and that's exactly where MISP is put into place. As you see, the comprehensive SRH services, the initial planning of that is started. But what happens is that coordinators should plan for the comprehensive information and services as soon as the situation allows them. So while the restoration is happening and there's relative stability and things are returning to normal, only then the comprehensive SRH services are put into place. Next. We take you through this cheat sheet. Now this cheat sheet talks about the 5 core objectives of minimum initial service package, as well as the subcomponents of each of the objectives. For example, objective will set out a broad outline of what is to be done, and these sub actions will be the activities which will help us implement and achieve that objective. So the objective 1 would be to ensure health clusters, sectors identify an agency to lead the implementation of MISP. Usually, from our experience in almost 20 states, we have seen health department taking a lead, disaster management taking a lead, and of course, some other departments or the civil society members have taken a lead in some of the states. Now, vis-a-vis this, an RH officer, reproductive health officer needs to be in place, meetings need to be initiated, and this officer needs to report back to the health cluster on giving the feedback on what are the requirements, what are the needs, how does this need to be developed, and how are the RH kits need to be, what kind of RH kits are required. Now, we also have under the MISP some reproductive health kits. Now, these range from 0 to 12 in number, and which are for specific, activities and for specific ailments. Like we have something for maternal newborn neonatal health, and we have something for HIV, so these are RH kits. And if you have a look at all the objectives, you'll also see that this has associated RH kits also involved in each one of the objectives. Objective 2 largely talks about prevention of sexual violence and assisting survivors, which will be largely talking about the protection, knowing about the protection systems, how to put them in place, especially for women and girls, medical services and psychosocial support available for survivors. What are the pre-existing services which are available, and during disasters when they become defunct, how do we help out by having this RH kit 3 and RH kit 9 into place, and community awareness of services, so these kind of things are come under the objective number 2. The objective number 3 is largely talking about reducing the transmission of HIV, which talks about having safe and national blood transfusion in place, standard and universal precautions being practiced and followed, especially during disasters, sterilizing, and all the things which are usually not taken happen, and that's why it leads to so many STIs and HIV cases. And free condoms should be readily made available in disasters. And this also will have RH kit 1, standard precautions are through and through overarching, included in all the kits from 1 to 12, and the RH kit 12 will also be included under this objective. Objective 4 largely talks about prevention of excess maternal and newborn morbidity and mortality, which talks about EMONC facilities, which is emergency obstetric and newborn care services are available. 24/7 referral systems are established. Clean delivery kits are provided to birth attendants and visibly pregnant women, and community awareness of services is established. Now, we have seen during the previous disasters, a lot of humanitarian organizations are providing these clean delivery kits to the government, to the visibly pregnant women, are handing them over to the birth attendants so that these things are taken into account. So the objective 5, it talks about the plan for comprehensive RH services. As we said, that we do the initial planning in which we collect background data, we identify sites for future deliveries of comprehensive RH services, and then we also assess staff capacity and trainings, and what is the kind of RH equipment that would be required in the second phase. Next. So these subsequent slides are actually a repetition of what we have said, but yes, I would like you to take you through this. Rolling out of MISP will ensure vulnerabilities of women and children do not get further compromised, that basic reproductive health services are available, health providers are trained and available to meet service needs of women during crisis, and administration has developed linkages to cater to multiple health and security needs of women and children. Now, these are the good stories. These are after a lot of integration in different states, in different districts, that these are some of the outcomes that have been achieved. Again, objective 1 and 2 will talk about some of the actions and activities. Next. These have already been discussed, especially the need for having an RH coordinator and SRH coordinator to be in place, who will work as a central person and coordinate and facilitate coordination with all the important key stakeholders who are involved in this. It's not a standalone activity. Many key stakeholders have been engaged, which we'll subsequently come to know and understand. Sensitize individuals for the need for MISP in disasters, prevent and manage consequence. Most of these things we've already described. So we'll skip through these 2 slides of objectives and then come to the outcome of MISP. Dolphy? Yes. So the outcomes of MISP would be, 4 things of which we were discussing about back. Yeah, advocacy, which is raising awareness of policymakers and program managers on importance of SRH in emergencies. Now, we showed all of you these videos. These we have taken to all the states, to all the districts, and shown a very powerful advocacy tool to provide this rationale to substantiate what we are saying, that these cases do exist, and with a lot of data that has been collected by different research agencies, so that is the kind of advocacy that is required for for convincing, motivating the policymakers to roll out these initiatives in the state context. Coordination, without coordination, MISP will not work. Coordinate, implement MISP in RH and emergencies, and establish state and district teams to support. As I said, a lot of stakeholders are engaged in this. We talk about reproductive health, so that comes under the prerogative of the health department. We talk about prevention of sexual violence, so that comes under the prerogative of women and child development department. We talk about family planning, which comes under the HIV wing. And then we also talk about some social issues. We also talk about a whole lot of other security, where police, army, civil defense, and such volunteers have also been a part of this initiative, and also provided a lot of support in rolling and implementing these in the field. Without their support, this would not have been possible. So at the national headquarters, we had, NDMA, NIDM, Ministry of Health, and so many other actors helping us roll it out, the UN agencies, UNFPA, so many other organizations also. Capacity building. So the idea is to build the capacity, build a lot of knowledge, learning among the people who are in the field, who are at the helm of, like, these doctors, like, professionals, like disaster management practitioners who are at the disaster sites. Building their capacity in MISP is extremely important. And policy or integration, which is like integrating these in health plans, in disaster management micro plans of districts, and disaster management plans of states. So that is where we are ensuring that if we are including these activities in the normal scheme of the day-to-day actions of the government, so even when we continue doing these capacity building, then the state will embrace it, and then it'll be more sustainable in terms of its operation for any subsequent disasters. Next. Now, these are also repetitions, but the idea is to reduce mortality, morbidity, disability among populations affected by crises, particularly for women and girls, increasing the capacity to implement MISP SRH during disasters, strengthening coordination, responding in a very timely and effective manner to SRH needs in disasters, enhancing access to comprehensive SRH information and services, and integrating MISP in disaster management and health plans. Now, who is MISP for? As I said, this is for health disaster management professionals responding to disasters, humanitarian workers operating in health, camp design, management, community services, protection, and other sectors. MISP is also for members of emergency response teams, and it's also for first responders in crisis situations like Red Cross, Civil Defense, SDRF, Army, Police, volunteers. So these have been our main recipients at the state level for rolling out this initiative. Next. We come to a very important slide, which is why I am here and why I am discussing this with you. Now, SPEAR advocates for the adherence of global SPEAR minimum standards. It has, this is the SPEAR Humanitarian Charter and Minimum Standards in Disaster Response has very clearly outlined MISP for SRH as a minimum standard of a care in disaster response, with a goal to reduce mortality, morbidity, and disability among populations affected by crisis. So, as I said, this is very critical, and under the health indicators, this finds its position, this MISP standard. So that is why we are advocating for this. And comprising of this, it's very clearly outlines that talks about the planning for integration of good quality comprehensive RH activities and their integration into primary health care at the onset of the emergency. It talks about how the interagency working group can develop an interagency emergency health kit, which includes information on these some of the commodities and supplies for patients post-exposure prophylaxis, for medicines for midwifery, and for all the other supplies that are required for MISP. It also has clearly laid indicators for sexual violence and for emergency obstetric and neonatal care. Now, under the 19 health indicators, one of the core indicator is on sexual and reproductive health also in this global SPEAR minimum standard guideline, and that is what we are advocating for through this exercise. Next. Another very important thing is that without coordination, this exercise, this particular set of coordinated action, which we were talking about, will not be possible. So again, acknowledging the contributions and the support, technical support, and all the other support provided by all the relevant stakeholders. And it's only because all of them got together that we were able to develop this slide. Now, who are all the partners who have provided support in this? As I've already mentioned, quite a few of them: NDMA, central ministries, women and child development, NDRF, SDRF, state and district disaster management authorities, and so on and so forth. And UN agencies, NGOs, CBOs, Red Cross, community, even local population affected by disasters, all of them have been partners, and it's because of their coordinated support this action was made possible. If we can quickly move to these two slides which show the framework of the legal institutional framework in the country as per the Disaster Management Act. Now, this is a very, this has been rolled out in 13, so this was included in the module. I don't know whether there have been any improvisations, I apologize, but then this is the chronology. The idea behind this is to show how from the national level to the panchayat and municipality, we have ensured that all with the coordinated approach and coordinated support of all the relevant stakeholders, we were able to institutionalize and we were able to kind of integrate SRH components into the both the policy programming as well as the implementation status. Next one, which is also quite similar and talks about the national disaster management structure with some of these important high-level committees at the ministries, and then at the state level, the SDMAs, and the specific line ministries as well as the districts. So from the state to the district, these have been people whom we have engaged with for executing this action based on these four broad categories, which are advocacy, capacity building, and policy integration. And they have extended all their support. Next. Now, some of the milestones achieved so far is that, the first TOTs on MISP of a skeletal module were done in Delhi, Hyderabad, and Northeast. This was somewhere in 2011, I think. Pilot tested in Goa, and during the emergency management exercise in Guwahati in 2012, the manual was finalized and launched by NDMA in 13. And at the state level, constitution of committee for SRH and advocacy with district authorities, and advocacy with policymakers and program managers. This is the sequence of events that we have done in all the states where we have implemented MISP. And establishing a core group, guide, monitor, supervise state and district level activities, conducted state level MISP TOTs, integrated MISP in state training institutions, which are ATIs and SIHFWs, and integrating them in state disaster management plans and health plans, and allocating budget for MISP interventions. In Odisha, in Maharashtra, in some northeastern states, the governments provided, the health department as well as the disaster management department allocated a lot of funds under this action, and coordinating with 4 line departments from health, family planning, WCD and other departments. So a lot of willingness, a lot of robust, active involvement and engagement of various stakeholders made us roll it out more effectively. And then at the district level, subsequent slide, Dolphy. Yeah, so we followed a similar process here as well. The only thing which has changed here is that here we were opening vernacular channels. So translations in regional languages might have been required, which were done in some of the states. And we were also thinking of formulating SOPs for GBV right from the state and the district level, which would have a very bottom-up approach, and then it would frame into the policies. So some quantum leaps were made there. Quickly, if we can move to the next slide. Constitution of committees at the state and district level. Now, these are the different officers who were a part of the committees for SRH in different states. Now, this being, I think this was Maharashtra or some state. And similarly, we followed a similar suit for other states as well. And next. I have explained most of these. We are very thankful to the technical support provided by NDMA, Ministry of Health, and DM authorities for the rollout in the targeted states. Ownership of the state government to integrate MISP in the health PIPs. And it was rolled out, I think there's some mistake here. It was rolled out in some 18 to 20 states, and we have reached out to almost 3,000, more than 3,000 people who are advocates now for SRH and of their own conducting these activities in their respective context. What is interesting to know that MISP was integrated in 143 district disaster management plans and 8 state plans. And the breakup of this is provided here, 38 DDMP plans, and this was during the post BCDRR, because we also had a thematic presentation on SRH, which was considered and also integrated in the BCDRR action plan for 2030, I think. And then 22 DDMPs of J&K, 5 DDMPs they had already integrated, other 17 would be integrated. And then subsequently, next, 12 micro plans were developed in the state of Odisha on state health disaster contingency plan. And we did this was achieved during the integration workshop only, because we had kept the structure ready, and it's just that during the workshop for the entire day, all the health officials and all the different line departments came together and developed these 12 very exhaustive district micro plans with a specific focus on SRH in emergencies, very well aligned with the MISP components. 36 DDMPs in Maharashtra integrated MISP, 16 DDMPs in Manipur, 8 in Mizoram, and 7 in Meghalaya, and 4 in Sikkim. So next. Some of the other provisions, as I said, 19.7 lakhs were provisioned under state PIPS annual fund for the year 13-14 for capacity development and procurement of RH kits in Odisha. Similar provisions in Maharashtra, J&K, and Sikkim were initiated, and 12 MISP micro plans were developed, as I already said. So next, opportunities. As I said, this was integrated, MISP was integrated, and GBV was integrated in the BCDRR action plan roadmap. And we also integrated in some DDMPs, and the MISP track was included in the Guwahati emergency management exercise by the Assam State Disaster Management Authority. 63 government officers were trained in MISP. few sessions of MISP will be integrated in the ASHA modules as well. So I think this is a very exhaustive exercise, but yeah, if we can go to the way forward and then we can close the session, and because I think we are running down on time also. Way forward. So way forward and the way forward would be that continuing advocacy with NDMA and MOHFW and secretaries and National Health Mission, and conducting trainings to build capacity of government and other humanitarian actors, formulating SOPs, assembling RH kits, and integrating MISP. Again, in plans, it has to be a very continuous and a very sustained effort by all the actors. Only then we'll be able to achieve the outcomes. So I think I'll close it here, and I'll give it back to you, Dolphy, for having a more interested session from Anuba, who will give us a human rights perspective to SRH. Thank you so much.
Thank you so much, ma'am. Thank you. And it was like I was back in my classroom, in disaster management classroom. So thank you so much for first bringing the basics out and then going and talking very technical specifics as well. Thank you so much. So now I would like to invite Miss Anubha Rastogi. Ma'am, are you here? Can you hear me? Yes, we can see you. Yes, so I have made you the presenter. So and you can present in any way that you like. So before we go further, I would like to give a brief introduction for you as well, so that everybody knows who the speaker is, right? So just a moment. Miss Anubha Rastogi is a litigating lawyer, and she has over 18 years of experience. Hello? Hello, am I audible?
Yes, you are.
Yes. So I was saying that she has, as a litigating lawyer, she has over 18 years of experience, and she has worked with Women's Justice Initiative of the Human Rights Law Network, where she assisted women from different walks of life to access justice and also represented issues in PILs. She has worked closely with a global software company to ensure that the workplace was free from sexual harassment and discrimination. She then worked with the Center for Equity Studies and was part of a legal audit done on the state response in 7 specific post-partition communal massacres in India. She is actively involved on issues of sexual and reproductive health and rights, and has authored Assessing the Judiciary's Role in Access to Abortion in India, Part 1 and Part 2, which is published by the Pratigya Campaign for Gender Equality and Safe Abortion. She also works on issues of workplace discrimination and harassment, as earlier described. She is basically based in Mumbai, and she's also a special prosecutor for SEBI, that is Securities and Exchange Board of India. Thank you so much, ma'am, for being here. Over to you. You can go ahead with your presentation.
Thank you so much, Dolphy, and thank you to the National Institute of Disaster Management for organizing this session. It's very, very required. And I'd really like to thank Dr. Hina Hijazi for the excellent context setting, and also putting out really in detail the intricacies of the MISP, and looking at how this builds into our international commitments, not only on SRH, but also on dealing with disaster as such. Thank you so much for that context setting, and it's made my job fairly easier in that sense. So I'm going to primarily focus on how this really fits in within our legal system, within what the Constitution identifies for us, what the courts have been saying, and then also contextualizing it in something that we are all absolutely familiar with at this point, which is a situation like the COVID situation that we are in right now. But again, I'd really like to thank Dr. Hina for also setting this right, that it's not only something like COVID that is a disaster. And I'm sure, I mean, everyone here knows that, but it's just a good reflection for me also to reiterate that that disasters are there in various forms, and one or the other part of our country is constantly dealing with something like that, be that drought, be that floods, be that landslides. And then we have something like the pandemic, which has really shaken us up in that sense. So just let me take a few steps back in the sense, and really look at where this conversation about ensuring that there is access to some minimum standard aspects within the SRH regime. Where does that really come from when we look at our own legal regime? So we all know that we are a constitutional democracy. What does that mean? That means that we have a written constitution which really governs how the legal system, how the executive, how every branch of the country really works, of the government really works. And very clearly, the Constitution has some non-negotiables. And those non-negotiables are the fundamental rights. And let me, and I'm very, very careful of the choice of words that I use here. So fundamental rights are not given to anyone, because these are not rights that can be taken away. These are rights that the Constitution acknowledges. And it acknowledges not only for its citizens. There are fundamental rights which are acknowledged by our Constitution for even persons, which means that even if a person is not a citizen of the country, there are inherent rights that our Constitution acknowledges that this person has, simply because this person is a human being. And so therefore, these are not rights which the Constitution gives us. These are the rights that the Constitution acknowledges. And what are these rights? I'm sure we all know this, and it's not something that we stop and think really. But the right to life, the right to health, the right to movement, the right to assembly, all of these are within our fundamental rights. The right to free speech. But in a pandemic situation, what happens is that there are some curbs on these rights. For example, when we look at the COVID situation, we can't say that the right to move freely is my fundamental right, and therefore you cannot restrict my movement. Why? Because this is within the constitutional framework. The situation is such, the emergency situation now is such, that the law within the NDMA Act gives rights to the authorities within the Act to also bring in some curbs to ensure that the spread of a particular disaster is reduced to the extent as possible. But even in that, even in a situation where there can be some curbs, some restrictions which are brought in, there are fundamental rights which are completely non-negotiable. And in that is this large regime of the right to life, which we have in our Constitution. It's the Article 21 of our Constitution of India, and it is the most interpreted provision of law in this country by the High Court and by the High Courts and by the Supreme Court. So within the right to life regime, we bring in multiple rights, which includes the right to health. And I'm right now restricting myself to the right to health is also because I want to then get specific to the sexual reproductive health rights and really get specific on that regime. So within the right to life, we have the right to health. Now, what does it mean when we say that we have the right to health? Does it mean that, yes, the court has declared that, yes, every person has a right to health and that's it? No. How is it that a right which is then declared or which is acknowledged either in the Constitution or by the court, how is it ensured that that right is actually brought into practice? So when we talk about the right to health, we talk about the infrastructure that is required. It's not enough for me to say that, yes, I have the right to health and stop at that. It also means that the government is duty bound to ensure that all the kind of infrastructure that is required to ensure that the right to health of each person within its jurisdiction is facilitated, is there. So what does that mean? That means that you have physical infrastructures, like you have hospitals, you have PHCs, you have CHCs, you have the district hospital, etc. It also means that not only you have these physical infrastructures, but you also have people, you have workforce, you have human resources. So you have enough number of nurses, Anganwadi workers, ANMs, male nurses, female nurses, doctors, other specialists, radiologists, etc. Then the third aspect of that is that you have enough number of medicines and drugs available. And not only are they available, they are also available in a manner which is accessible. So it's not necessary that they are available, but they are unaffordable. So they need to be in a manner which are affordable. They need to be in a manner which are acceptable. It cannot be a form of medicine which may not be acceptable to the local population. So even that needs to be seen by the implementing authority, that whatever other drugs and provisions and medicines that are being provided, they are something which will be acceptable to the general population. And lastly, what is really important is that there is information available. Information about the fact that these are rights, information about the fact that these services are available, that these services are available at either no cost or at so and so cost, and that how are you expected to use these services. So for example, now if I contextualize and talk about a basket of choices as far as contraceptives are concerned. So it's not enough that we at every level, at the local level, at the most local level possible, we have the basket of choices available in terms of be that contraceptive pills, be that condoms, be that long-term contraceptive methods, operations, etc., patches, all of those. It's not enough that all of those are available. It's also required that there is information about those, about what they do, what are the side effects, if any, how is it supposed to be used, what are your rights, what is there any scope for any insurance in this process, what is to be done where in case there is there's any misuse, or if there's any negligence. All of that information is expected to be available, and not only available, it needs to be available in a language that that the local population will understand. And with all of this, what is really required is that privacy of the people who want to access these services is maintained. Because not everything is something that can, especially in the context of sexual reproductive health rights, all of these aspects are decisions that a lot of times people and a lot of times women prefer making when they are able to decide these things of their own and not in a public setup. So the service also has to be in a manner, especially in the public health system, where it is in a form which will maintain the privacy of the patient, of the client who's seeking that information, who's seeking that service. Now, all of this that I have said is something that is expected to be there as it is, even in normal circumstances, so to speak. I know the definition of normal is very, very rapidly changing, but be that as it may, these are the standard things that are expected to be in existence, even in a normal setup. Now, if we contextualize this and bring in the layer of a disaster. So if we are talking about the access to a primary health center, say in a semi-urban or a semi-rural situation in a state in the country. And within that, then we bring in the context of either a drought or flash floods. Then obviously the the priority of the local government changes. But what has been repeatedly reiterated by Dr. Hina, even in the presentation before, is that even though priorities may change, and they are expected to change when you're dealing with some kind of an emergency situation, there are some things which continue to be non-negotiable, if I can use the word again, because the understanding is that irrespective of the emergency situation, irrespective of the disaster situation, these are needs which will continue to which will continue cropping up. Be that the monthly cycle that women go through, be that the need for continuing contraceptive care, be that the need for counseling in terms of pregnancy or in terms of abortion, be that the need for accessing prenatal or antenatal care, be that the need for accessing safe and legal abortion services, and then contraceptive services if required. So, and continuing the information about all of this, because even though a disaster is taking place, even though we are in the situation of a pandemic, etc., biological cycles will continue moving. Adolescents will continue growing, and their needs, both sexually and reproductive needs, will keep altering, will keep changing. So not only is it required that these services are there, but even information about these services needs to continue being accessible. And it becomes extremely difficult because obviously the workforce is also constrained. There isn't enough workforce. Even in our normal situations, we don't have all the infrastructure that is required to be in place, be that in terms of the hospital setup, the primary health center setup, or even in terms of the human resources that are required. So in a normal situation, when we are not 100% equipped, obviously in a situation of disaster where some things take priority over the other, and we still are not 100% equipped, there will be far more pressure on the existing infrastructure. But the idea is, the whole rationale of having something like an MISP, etc., is to ensure that these kind of situations will still not will not ignore the sexual reproductive health needs and health rights of not only the majority population, but specifically of the adolescent population, which is what will really take the local area, take the state, take the country out of any such disaster situation, and will actually move ahead. So having said that, we started with the Constitution, with the fundamental rights, with the right to life. Within the right to life, we came to the right to health. There are some specific cases in which the right to sexual and reproductive health and rights has also been specifically recognized, especially by the Delhi High Court in a couple of judgments, by the Bombay High Court in a couple of judgments, and recently we have seen in the right to privacy judgment of the Supreme Court, which was primarily based on the Aadhaar issue. But there was an entire discussion, judicial discussion, that took place in the judgment on really trying to find where does the right to privacy really fall within our constitutional legal regime, and within the right to privacy, what are the other rights that can be attributed to the right to privacy. And it gives me an immense pleasure to say that even access to sexual and reproductive health services, including specifically access to abortion services, has been held by the Supreme Court by the various judges of the Supreme Court to be a very, very important facet of the right to privacy of an individual. And with this, it includes, like I said, it's not only about the service, it's also about information. Even today, there are a lot of populations within the country who do not know that access to abortion is legal in this country. that within the framework of the MTP Act, you can access safe and legal abortion services and you're not committing a crime. So even that basic information is something that needs to be out there consistently, and not only consistently, but even more so in a situation of disaster. When we talk about right to access to abortion, and we spoke about the right to privacy, we also spoke about how accessing these services becomes a major part of how really how one can really implement the right to health. You know, and the reason why I'm going more into the detailing of what is the perspective that you need to look at when you are really sitting at the drawing table, drawing up policies and or implementing policies at the local level, at the state level. It's because you need to consistently remind yourself that there is a right here. It's all of this that you are doing, all of the work that is coming out is emanating from someone's rights. And if there is anything that is not done at par, it is someone's right which is being infringed. And the moment you start looking at these policy documents or these programs from that perspective, it will be easier for you to also find out what is the best way to implement to ensure that someone's rights are not being infringed by the wording of a policy or by the implementation of a policy or by the lack of some resources, etc. So it's access to health services is an important and integral part of the right to health. And that access, when it gets compromised due to a pandemic situation, like let me now take the example of COVID-19. When lockdown was announced in March of 2020, immediately everything was shut down. And in fact, even the FOXY, that's the Federation of Obstetrics Gynecologists Society of India, it came out with a statement saying that that the services that they provide in terms of maternal health are emergency services. And it was quite unfortunate that in their first statement, they did not refer to access to abortion being an emergency service. Because we need to understand that access to abortion is something that is completely limited by time. And it's limited by time not only by our own law, it still is 20 weeks, even though the law has amended, but because the rules and regulations have not been drafted and passed yet, so the date of enactment has not come out yet for the new law, for the amended law rather. So in any case, the law provides that it is only up to 20 weeks that a woman can seek access to safe and legal abortion services. And the decision to terminate a pregnancy or not is extremely time bound. And in that, if you say that access to abortion is not an emergency service, then there are so many forced pregnancies that you are forcing on women or forcing on pregnant persons by just completely ignoring the fact that this is also a service which is time bound and which requires timely intervention. Because if it's not a timely intervention, a termination of pregnancy that can take place by medical pills will have to then later be done by a surgical method, which means an invasive operation. While if this decision was accessible earlier and could have been taken earlier, it could have been as simple as the woman under prescription and under the directions of the registered medical practitioner taking the combi pack pills and managing to actually be able to get a safe and legal abortion within the confines of her own home if required, if she does not require admission in the hospital, etc. So just imagine that in a situation where there is restrictive movement, there is restrictions on what are the kind of health services that are available. if access to safe and legal medical abortion pills are provided, and are easily available, at the level of the doctor itself who's prescribing the medicine, it becomes so much simpler for a person who wants to access abortion and is within the law to access abortion, to actually access abortion. Similarly, when we speak about access to contraceptive services, for example, there are studies that have been done by the IPAS Development Foundation, by the FRHSI, by the Pratigya campaign, which also looked at what are the kind of statistical numbers of unplanned pregnancies that will happen because the access to abortion services and the access to contraceptive services has become extremely limited in the COVID lockdown situation. So the fact that there would be so many unplanned pregnancies, the fact that because there is restricted movement, a lot of women have faced domestic violence, because now there is nothing that comes in between and the domestic abuser, because everyone's at home now, and which has also resulted in a whole lot of sexual abuse of women, resulting in unwanted, unplanned pregnancy, forced pregnancies on women, where if they had at least access to contraceptive services, if they had access to counseling services, for example, if they had access to some kind of legal domestic helpline, there are situations that a lot of women could have prevented finding themselves in. But the fact remains that, given the fact that the pandemic is of such a nature where public gathering is not advisable at all, and it is insisted that people should remain within their homes, what is really required is that an institute like the NIDM, etc., also looks at how do situations of this nature, like domestic violence, like forced pregnancies, like lack of access to sexual reproductive health services, contraceptive services, abortion services, how can these situations also be dealt with within the context of the region, within the context of the country, within the context of the state? Obviously, the policy that gets developed for, or has been developed for an urban setup like Mumbai, for example, would be very different from what is developed for, say a Raipur, for example, or for a state in the Northeast, for example, different geographical terrains, different metropolitan areas, etc. So that it is very, very important that all of these aspects, all of these parameters that have been set out, agreed upon internationally in the form of the MISP by the Reproductive Health Working Group, have been spearheaded by Sphere, how they actually result in specific interventions which are catering to the need of the population at hand in the local jurisdiction area. While it is fabulous that we do have these policies, Dr. Hina also showed us some of those policy documents. What remains to really be seen is that how have they been implemented at each district level? What has been the response? How accessible have those services been? For example, in Bombay, let me say that a whole setup of women's groups set up this entire WhatsApp list of organizations, list of helplines, list of lawyers, list of shelter homes, which were accessible for women who were facing any kind of domestic violence and crisis situation during the pandemic. They would also do sort of a tie-up with the local police so that the movement of the woman can be unrestricted if she wants to leave her house where she's facing violence and wants to go to a safe space. So it's these kind of interventions, while we cannot entirely prevent, the kind of lockdown situation that we found ourselves in. What is really important is that keeping the context of where we derive our rights from, that at every moment there are people who are able to access services, who are able to access help when they need it, even though it is a disaster situation, even though it is a pandemic situation. And I'll take my last couple of minutes to also talk about some of the sort of unique situations that our young people find themselves in our country. More so because of laws which do not recognize sexual agency of persons below 18, and any sexual activity between a person where a person below 18 is involved is seen as an offense under the law, under POCSO. And how that really plays out is because even if it's a person who has consensually entered into a sexual intercourse with her or his boyfriend, etc., and has resulted in this person becoming pregnant, because POCSO looks at it as an offense, any access to services also becomes conditional in a sense, because POCSO asks for mandatory reporting. So in fact, what happens is that even if she wants to access an MTP service, there will have to be the entire setup of an FIR being lodged, her boyfriend, her partner being arrested, especially if that person is above 18, so is not a juvenile, and statements being recorded only once the FIR has been lodged. Only after that the doctor is being able to provide the service, MTP service. And then look at all of this in the context of when there is a lockdown. There were cases during the lockdown where I was providing legal assistance to some people who were trying to access MTP services, and there was the POCSO at play, and it made situations far more difficult. So the point I'm trying to make here is that in any case, our laws, our policies, our realities are extremely layered. And in that, when we bring in the context of a disaster, which could either make accessing spaces difficult or makes stepping out of our homes difficult for whatever is the disaster situation that we're dealing in, it adds a couple of more layers to an already difficult situation. And that is the kind of context that any policy, any process, any implementing guidelines that come out of the institute deal with. And lastly, the two things that I would like to talk about is that even during the pandemic, Dr. Rolfi had said that I had co-authored and authored two reports where we were looking at, as part of the Pratigya campaign, we were looking at what has been the role of the judiciary in accessing, in providing access to abortion. Since 2016, we had seen that there were a huge number of cases of women going to the Supreme Court first and then to the High Courts, seeking permission of the court for termination of a pregnancy, which was usually either above 20 weeks. And in a number of cases was even below 20 weeks. And the understanding was that without the court permission, we cannot get an MTP done. A flawed understanding, a completely wrong understanding, but that was the understanding. Now, during the pandemic, the access to courts was also very, very restricted. It was only for extremely urgent matters. It was only virtual, etc. Even in that situation, almost all the high courts in the country were seeing at least 4 to 5 cases every month of someone or the other, some woman who's pregnant or some minor who's pregnant and is seeking permission of the court for termination of pregnancy. The point I'm trying to make here, that even in the most restricted situation, access to abortion and permission for termination of pregnancy was something that the courts were still seeing. So even in that kind of a situation, if we are not providing access, we are ignoring it, or it slips our list of things, it's the consequences of that are so huge. And only let me again say that in the last 4 to 5 years, close to 600 700 women have approached the courts seeking permission, but these are only the 600 700 women who have actually approached courts. I mean, 600 700 is a huge number, but when we look at the number of women who actually access abortion, who are or who get pregnant, 600 700 is a minuscule minority. So you can imagine that the number of unplanned pregnancies or forced pregnancies that continue because of the situations that we are in. The last thing that I would like to point out is that there was by the MOHFW, there was a fabulous intervention of bringing out the telemedicine guidelines. However, where the telemedicine guidelines were completely lacking was that it still did not specifically deal with sexual reproductive and health rights and services. It did not include within its fold access to abortion, access to contraception. It only, while the guidelines are fabulous and I think they can be used in any situation, it narrowed itself down to only being accessible for repeat medicines like diabetes, BP, etc., and for basic things like fever, etc. While it could have brought within its fold things like access to abortion, access to contraception, continuity of care for in terms of maternal health, neonatal health, antenatal, postnatal care, etc. It could have brought in all of that, but since the guidelines exist, I would think that it would be a great opportunity even for the NIDM to suggest that something like a telemedicine module can be used to further access to SRHR services during a disaster situation. I'll stop here, and if there are any questions, thank you.
Thank you so much, ma'am. Hello, can you hear me?
Yes.
Thank you so much for laying the grounds for the laws and very specific laws like POCSO and such for all of us. And now I would request all the participants, if anybody has their questions for either of the speakers, they can post them either in the chat box or in the question and answer box, and we will be taking those questions. So Dr. Hena, are you there? So can
Yes,
we go ahead with the question answer session?
Yes, please.
Yes, okay. So Dr. Vartika? Hello, Dr. Vartika. Yeah, so I would like to now invite Dr. Vartika, who is the Junior Research Officer in CCDRR Center, to go ahead with the question answer session. So over to you, Dr. Vartika.
Thank you, Dolphy, for giving me this opportunity. I was listening to both the speakers, and it has been a very wonderful talk. And I would congratulate both the speakers for such a wonderful talk, and also congratulate you for organizing such an important, I would say, topic. Which is so relevant in the present times as well. Looking at the questions, we have a couple of questions. So from Pooja Singh, there's a question from Pooja Singh. Is there any provision to get menstrual hygiene products for women who cannot afford them? So I would request any of my speaker to take this question and can answer this.
Can I respond to this? Yeah, thank you so much.
Yes.
So we are talking about provision of menstrual services for people who are affected by disasters, emergencies, or we are talking about peace times? Can we get more clarification on the question?
It is during the disasters, because I hope because it's just it ends with women who cannot afford them. So I'm hoping that it is intended for disaster time, because the topic
We
is on
are talking
disasters.
about the
So,
session which talks about SRH in disasters, emergencies,
yes.
in such contexts, right? In normal contexts and routine services, we already have health services providing these kind of services in different contexts. If they want us to connect to any specific people, they can post those specific address and where they are from, so that we can get them in touch with the relevant officers. But it has to be the health department whom they will have to approach, their nearest PHCs or their nearest health service stations, or some of the other organizations who may be responding to this. We also have IAG members in different states, so we may put out their needs. If these are collective needs coming from more than one or two, or if there are many families who are grappling under these problems, they can put in their requests to us. We can approach our IAG members from those states and see if there are civil society organizations, international organizations, or UN organizations who are responding in similar setups to help people go through these problems. But today the questions are more of in disaster scenarios, in emergencies, in pandemic situations, what are the services, SRH services that need to be in place. So I would appreciate if the questions are more aligned to that. Thank you so much. Is there any other question, Vartika?
Dr. Vartika, we are not able to hear you. I think you're muted.
Sorry, I'm
Otherwise,
so sorry.
not
Yes, I'm muted. Sorry. So then there are a couple of questions. The next question is, what is the role of the government to ensure the sexual and reproductive health of the women during disasters?
And I have spent almost an hour talking about a Government of India prerogative that, NDMA is Government of India, right? They've come out with this very elaborate document which clearly outlines how the services need to be made available for the public and for the most affected people at the time of disasters. I would appreciate if all of them, I can pass on the details of this manual as well as all the other details to Dolphy, and Dolphy can share it with all the participants who have attended today's meeting for their information, because they'll also go to their context and they'll also have this information which can be disseminated. This is open for dissemination. This is a Government of India guideline, and whatever my session was, it was primarily on the guidelines and the programmatic setup and the strategy developed by Government of India, which is NDMA, who derives policies, devices modules, derives programs. So yeah, Government of India develops these things. Now, implementation is the prerogative of the state government, and state administration. If we are giving more specific questions, I would like to respond to that. If this question would have come from a specific state talking about some risks or talking about some specific requirements, I would have responded, especially if this would have happened in the context of any disaster. We have Assam, we have so many South Indian states which are reeling under floods. We had Tokte, we had Yas, we had West Bengal, we had Odisha, so many of such examples. So if we can give examples of where these disasters have been, what are the services which have not been available, where are the human rights violations happening, we would be in a better state to respond to that. Dr. Vartika, are there more questions?
I think there's some issue with her internet. So let me jump in. I'll take
Next
the
question
remaining
is,
question.
a lot of women, it's from Sapna Singh. She asked, a lot of women have been facing menstrual issues, especially since the pandemic began. Is there a helpline or service that can guide them for this?
Helpline, I'm not sure, but at the time of disasters, we have something like a real-time feedback mechanism, which constitutes of a helpline, which is very integrated with the district emergency operation centers, state emergency operation centers, and with SPARE as well. We do come out with our own helpline systems as well, and we collect a summary of feedbacks which is coming from these disaster sites in terms of asking us there are specific requirements and needs, and then we complement and supplement the emergency operation centers who at the time of disasters are overwhelmed with a lot of activities. So yes, helplines do exist, but they are activated at the time of disasters and emergencies where the needs are coming out, where there are more risks, where there are more chances of exploitation, abuse, molestations, and all those things. So yeah. Otherwise, there are no general helplines. There are helplines. Childline is available, so they can have access if it is about a complaint from a child. But otherwise, for the others, they are usually activated at the time of disasters and emergencies.
Yes, we have one more question. I think it is more of like a law question, law-related question. So I think Anubha ma'am can answer this question. Pooja Singh asks that what are the remedies available with me if I think my health care provider has violated my privacy?
If the healthcare provider has violated the privacy of this person, I would think that it would really depend on what is the level of violation that we're talking about here. Is it something that's a criminal violation and therefore then the police, etc., can be involved? If it's something in terms of where information has been shared, confidential information has been shared, while that also is an offense under the criminal law, what can definitely be done is that this can be raised with the hospital management, if this is a hospital we are talking about, or with the concerned medical association that this particular health service provider is registered with, more in terms of negligence in provision of service. Because where even confidential information is shared without the permission of the patient and without the order of a court, that itself is a violation of privacy and can be taken up for sure. I hope that helps.
I think we are done with the questions, but I have a question as well. So any of you can comment that. Coming from like my research is on intersectionality of gender and caste. So I've been looking at women issues from the perspective of caste as well. So I think that when we talk about women, we cannot see women as a very homogeneous group, as a so we have category Adivasi women, we have Dalit women. So I think what will you suggest, both of you, coming from two different backgrounds, regarding the sexual and reproductive health of these women who are who comes from a different social, economic, and cultural backgrounds? So how we can have one single law or one single policy to maybe like talk about or to tackle these problems? I think that a single policy can handle the issues of women coming from different categories. Any take on that?
It's a very difficult question, Dr. Vartika, but a very, very good question. So you have mentioned that, we have vulnerable sections in a community, and then we have multiple vulnerabilities. We have women who are already considered to be vulnerable, especially when we talk about disasters, emergencies, and then we have women who are Dalit, who stand a greater chance of being, for example, raped at the time of disasters, right? Yes. So the legal provisions I would leave on Anubha to kind of comment on that, but certainly this is a concern where we need to integrate some policies which talk about inclusion of this particular at-risk component. And a lot of statistics, a lot of reports, a lot of needs assessment reports also come out with and also give us evidences that these people are the ones who are the most affected, who are the most, left out, and stringent policies and very good, reformations need to be kind of devised, kind of include them in the fray of normal access of services. A very good question. Anubha, you want to respond to the legal part?
Yeah. So and it's absolutely right. There can never be broad brush strokes when we are talking about we're talking about policies which need to be implemented and laws which need to be implemented for a diverse group of people. And within that, when we bring in caste, we bring in disability, we bring in sexual minorities, we bring in religious minorities, there are a lot of perspectives which need to be considered, which need to be handled, which need to be acknowledged and taken care of. And that is what I mean when I say that even when policies or even information, health services are being provided, even in normal peace times, so to speak, it's very important for the district level, the rural level, the village level health setup to ensure that whatever is available is something that is acceptable. Whatever is available is available, actually is accessible, is acceptable to all the population that it's catering to, irrespective of their caste, irrespective of their economic standing, irrespective of their religious standing, etc. And of course, all the other layers that also come in. Like a very good example of this is that because in Chhattisgarh, for example, there are communities, there are Adivasi communities which are very, very less in number. So there was a policy document, specifically a GR, saying that these communities, women are not permitted to get sterilization operations. Which you are in a bid to ensure that the number of that particular tribe keeps increasing. You are violating the sexual and reproductive health rights of the women within that community. So it's and this was overturned only when someone went to court and challenged it, etc. So the point I'm trying to make here is that even when our policies are so to speak trying to do something better, and I'm using the word better for the lack of a better word, really, by losing the context of what service you're providing and why you're doing that and what are the rights of the people involved. And that's why I keep coming back to every policy needs to keep in mind that you are dealing with rights of people. This is going to ensure that people have access to their own rights. And if we lose sight of that, that is where we have policy documents, we have words which are used which are very, very far away from what the reality of that particular place, of that particular individual is. And I think that is something that we really need to consistently keep looking at, no matter what we are drafting, a law, a policy, a GR, a guideline, anything.
And Dr. Vartika, another thing, under the rights in crisis, what we've started to do is that we usually come out with its rapid needs assessment after disasters, in which many of these marginalized sections, are not, the access to entitlements does not happen to them. So we've recently conducted a needs assessment in consultation with the state authorities in different states, post Tokle and Yas, to see that these scheduled caste, scheduled tribe people are included in the fray of social assistance and entitlements post disasters, who have lost their homes, who have lost everything. So they are also coming in that fray, and gradually by coming out with a lot of data. So our main challenges remains that we do not have a lot of data to substantiate that. So when we have that data and we do conduct home visits and we do consider them, that they are also equally and sometimes we are not getting hold of those people or not going to them. So we are also trying to include those in the fray. But this is going to be a very gradual process, but some initial quantum.
Thank you so much,
Yes,
ma'am.
thank
So
you
I
for,
also have just one doubt in the questions that were asked and in the answer. Like you said that, SRH services in disasters, they come into play after a collective needs assessment, or, you have these modules that have been made for a disaster that is a one-time event. Like, it happens, for example, an earthquake happens, and then the disaster in itself, the hazard in itself stops, and then you give these services. But in case of a biological disaster, like in the pandemic, which has been ongoing since March last year, it's a longitudinal disaster, so the disaster has not ended. So what are the services that are there? I mean, that is my question, that the post disaster need assessment will be different in the different states, will be different at different times. So is there any service which is permanent for COVID that has come out?
Yes, very good question. Thanks for raising that. So, of course, the strategy and the redressal mechanism will be different. We're not talking about MISP, and we're not only talking about SRH. There can be multiple issues that may arise post-pandemic from people. So, what we are trying to do is that teleconsultation can be one. These COVID cases, many of them reel under a lot of anxiety, a lot of depression. Some have suicidal thoughts. Children come out with their own anxieties. So people who are so frightened to go out, so these teleconsultation things are a new thing that is kind of emerging, and which is kind of eliciting a lot of data on people who are going through a lot of suffering. So one would be that in the process of having a one-to-one with the psychosocial experts who are there in the teleconsultation apps and who know how to filter out specific information, can also elicit this kind of response from different survivors, victims, or who have been post-COVID cases or have been indirectly impacted by the pandemic. So that would be one. Helplines would be another. Now we have many states coming out with helplines for children, and helplines for other people. So which could be another thing. There are also one-stop crisis centers. I'm not sure how functional they are in all the states, but these are umbrella, these have a very survivor centered approach. For example, you have a case of so they will not prefer to go to the police for the one reason of getting re-exploited, re-traumatized, so once a rape has happened, there's every probability that that person may again be re-traumatized in the process of getting some health care or getting some, we've many cases of that. So many states have come out with these one-stop crisis centers, or many organizations are also trying to see that we have a very survivor-centered approach in which psychosocial services, health services, legal provisions, and some other services, police services can be provided under one umbrella, which gives a victim a lot of security and safety. So these would be some other provisions that would be helpful in the pandemic times as well. But I don't have any questions because MISP is not for slow onset disasters. MISP is for sudden disasters. As I said in the start, crude mortality rate, 1 per 10,000 population per day. So the impact is humongous and many people are dying, and then in the fray of that, they are under a lot of risk. Slow onset disasters do not come out with, even if the wave 2 was entirely different, but we need to frame some programs accordingly for slow onset and longitudinal disasters as well. Thank you.
Thank you, Dr. Hina. Anubha ma'am, would you want to add to this, and then we can wrap up the session? Hello. I think she is not there anymore. So, okay. Anubha ma'am, are you there?
Yeah, I'm
okay.
here.
So yes, would you want to add something to it, and then we can, wrap up the
No, I think that was a pretty comprehensive answer. I don't think I want to add anything specifically to that, especially from the point of view of continuing policies and how interventions that keep changing due to the changing nature of a disaster really would impact. I think Dr. Hijazi has given a fabulous answer.
Yeah, thank you so much to both the speakers. And thank you, Dr. Vartika, for taking the question answer session.
One thing, Dolphy, or I want to add one thing.
Yes, yes.
That
Yes,
adding
please.
to everything, that how I think during the we are talking about women issue, that women coming from different social and economic backgrounds, and how we can have, you know, policies for all these women. So talking and discussing about it, it also brings me to think and to point out that we cannot think about these policies without having women as policymakers. That's very important. So when we see the ratio of women to men who are making policies for us is amazing. Like you see, if you see a panel of 10 people, there are 8 or 9 men sitting, and there is one woman who is making policies regarding men, women, and children. So I think that is very important, that when we talk about policies, we also need to talk about the representation of women in the top leadership positions, and who are the people who are making policies. Without having women and their experiences, women want, and how they want to make policies for themselves, or what they think about it, I don't think there is any relief having men making policies for women. So that's my final word to.
Thank you so much.
Thank
It's a
you
very
so much.
important one.
Thank you, Dr. Vartika. And thank you so much to both the speakers. And it was, such a wonderful session. And both the presentations were from very diverse backgrounds. So thank you so much. And in case anybody needs, we will be sharing the content with our participants as well. And just before I log out, just a note to the participants. You can you have to register at the NIDM portal, link for which I have given over here. You have to register there and then enroll in this program called SRH for Women and Adolescent Girls in Disasters. And then after 2 days, you can go back to the portal again, and you can download your certificate. So registration and enrollment, the deadline for that is tonight by 12 midnight. So whoever has not registered and enrolled, they can, go to the NIDM portal and do that by 12 midnight, and then can generate their certificate if they have 80% of attendance in the event 2 days later. Thank you so much, and thank you again, Dr. Hina and Ms. Anubha, for being here. Thank you so much.
Thank you.
Thanks
And,
to NIDM, Dolphy, and Dr. Vartika. Thank you once again.
Thank you very
Thank
much.
you. Thank you.
It was so nice being with you on the panel.
It was lovely.
Thank you. Thank you.
Thank you, ma'am. Thank you. Thank you so much. And okay. Okay. Bye.
Bye.
So I'm
Bye,
ending
everyone.
the event. Okay.
Yes.